In this lecture, we'll start our discussion with coronary revascularization, one of the most important treatment strategies in patients with coronary artery disease. Coronary revascularization aims to restore adequate blood flow to ischemic myocardium by opening blocked coronary arteries or bypassing them. There are two major approaches to coronary revascularization. One, percutaneous coronary intervention or PCI, which is catheter based. Two, coronary artery bypass grafting surgery or CABG, which is open heart surgery. Choosing between PCI and CABG depends on coronary anatomy, disease severity, patient comorbidities, surgical risk, and long-term prognosis. Percutaneous coronary intervention, PCI. PCI is an interventional cardiology procedure designed to relieve significant coronary artery stenosis without open heart surgery. The two principal techniques are balloon angioplasty and coronary stenting. Less commonly, plaque removal techniques known as atherectomy are used. These include rotational, directional, and extraction atherectomy. Atherectomy is particularly useful in heavily calcified or resistant coronary lesions. Indications for PCI. PCI is indicated in several clinical situations. The first indication is medically refractory angina, meaning patients continue to experience angina despite receiving optimal medical therapy. The second indication is non-ST elevation myocardial infarction or unstable angina with high risk features such as a high TIMI risk score. Another major indication is primary PCI in ST elevation myocardial infarction or STMI. Primary PCI is preferred perfusion strategy when it can be performed rapidly. PCI is also preferred in patients with NSTMI or unstable angina who are not suitable candidates for CABG. Overall, PCI is favored whenever rapid reperfusion can be achieved safely. Balloon angioplasty and intracoronary stenting. During balloon angioplasty, a catheter carrying a small balloon is advanced into the narrowed coronary artery. The balloon is inflated to compress the atherosclerotic plaque and enlarge the vessel lumen. However, balloon angioplasty alone has a significant limitation. Approximately 15% of patients develop restenosis within 6 months, mainly because of elastic recoil of the artery and new intimal hyperplasia. To reduce this problem, most patients receive coronary stents. Types of coronary stents. There are two major categories for coronary stents. The first is the bare metal stent, abbreviated BMS. The second is drug-eluting stent, or DES. Drug-eluting stents release antiproliferative medications such as sirolimus, paclitaxel, everolimus, and zotarilimos. These medications inhibit smooth muscle proliferation and significantly reduce new intimal hyperplasia. Consequently, restenosis rates decrease dramatically from approximately 20% with bare metal stents to about 5% with drug-eluting stents. An important clinical trial called PRAMI demonstrated that stenting non-culprit coronary lesions during STMI reduced cardiac death, non-fatal myocardial infarction, and refractory angina. Complications of stenting. Although drug-eluting stents reduce stenosis, they introduce another concern: late stent thrombosis. Fortunately, these complication is relatively uncommon, occurring in roughly 5 cases per 1,000 implanted stents. Because stent thrombosis may result in sudden myocardial infarction or death, prolonged antiplatelet therapy is extremely important. Adjunctive medical therapy after PCI. Following PCI, medications are essential to improve outcomes. Initially, aspirin and heparin reduce procedural complications. Additional reduction in ischemic events can be achieved using GP2B, 3A inhibitors. Examples include apixaban, eptifibatide, tirofiban. These drugs block platelet aggregation and are especially useful during coronary angioplasty in selected high-risk patients. Dual antiplatelet therapy. Perhaps the most important treatment after PCI is dual antiplatelet therapy, commonly called DAPT. DAPT consists of aspirin plus either clopidogrel and ticagrelor. Typically, therapy continues for 6 months, although treatment may extend up to 1 year depending on the patient's ischemic risk. For patients at high bleeding risk, shorter courses may be appropriate. Current evidence also support transitioning selected patients to P2Y12 inhibitors monotherapy after several months. In patients with a particular high risk of stent thrombosis, aspirin combined with prasugrel may also be considered. Procedural complications of PCI. Overall, PCI is remarkably safe. Mortality and emergency bypass surgery each occur in less than 1% of the procedures. Non-fatal myocardial infarction occurs in approximately 2 to 3% of patients. Other complications not listed here but clinically important include coronary perfusion, vascular access bleeding, contrast-induced nephropathy, and stroke. Coronary artery bypass graft surgery, or CABG. Unlike PCI, CABG creates new pathways for blood flow around obstructed coronary arteries. The primary objective of CABG is complete revascularization of the myocardium, restoring blood supply to all significantly ischemic regions. Indications for CABG. CABG is recommended in several important situations. First, patients with 50% or greater stenosis of the left mainly coronary artery benefit significantly from surgery because the left main supplies a large portion of the myocardium. Second, patients with 3-vessel coronary artery disease, where each major coronary artery has at least 70% stenosis, are excellent candidates. CABG is also indicated in patients with significant proximal LAD disease accompanied by another major coronary lesion. Survivors of sudden cardiac arrest caused by ischemia-producing coronary disease. 2-vessel disease associated with extensive myocardial ischemia. Significant proximal LAD disease with objective evidence of extensive ischemia. Multivessel coronary artery disease in patients with diabetes mellitus. Left ventricular systolic dysfunction, especially when the ejection fraction ranges between 35 and 50%, provided viable myocardium remains. Persistent angina despite maximal medical therapy when coronary anatomy is suitable for bypass surgery. Contraindications to CABG. Although CABG offers excellent long-term outcomes, it is not appropriate for every patient. Contraindications include patients who are extremely elderly or frail with multiple serious comorbidities and therefore unlikely to tolerate surgery. Patients without viable myocardium, because restoring blood flow to death myocardial tissue provides little benefit. Finally, CABG is contraindicated when suitable bypassable coronary vessels are absent. Result and outcomes of CABG. Modern CABG has excellent safety. The preoperative mortality rate is approximately 1% in low-risk elective patients. Across all patients' populations, mortality average are around 2% depending on individual's risk factor. Several variables increase operative mortality. These include age greater than 80 years, female sex, emergency surgery, left main coronary artery disease, extensive multivessel coronary disease, severe left ventricular dysfunction, and previous CABG requiring redo surgery. Despite this risk, CABG remains the preferred strategy for many patients with complex coronary artery disease because it provides more complete revascularization, superior long-term symptom relief, and lower rates of repeat revascularization. Table 12. Choice of revascularization procedure. The first table compares the advantages of PCI and CABG and explains when each treatment should be preferred. Advantages of PCI. PCI is a minimally invasive catheter-based procedure performed through the radial or femoral artery. Compared with surgery, PCI offers several important advantages. First, it is less invasive, meaning there is no sternotomy and no cardiopulmonary bypass. Second, patients generally experience lower immediate procedural morbidity and mortality, especially in low-risk individuals. Another important advantage is the shorter hospital stay. Most patients go home within 1 or 2 days and recover much faster than after open heart surgery. Because of these benefits, PCI is particularly attractive for elderly patients or those with significant comorbidities who may not tolerate major surgery. Advantage of CABG. CABG is a major surgical operation, but it provides several long-term advantages. The biggest advantage is more complete revascularization. Surgeon can bypass multiple diseased coronary arteries during one operation, including lesions that cannot easily be treated with stents. Another major benefit is the lower need for repeat revascularization. Unlike PCI, where restenosis or new lesions may require another intervention, CABG generally provides long-lasting symptom relief. Clinical factors favoring PCI. PCI is generally preferred in patients with severe medical comorbidities, advanced age, frailty, reduced life expectancy. These patients often have higher surgical risk, making a less invasive option preferable. PCI is also useful when severe medical conditions make surgery hazardous. Anatomical factors favoring PCI. Certain anatomical situations also favor PCI. One important example is patients with lower syntax scores, typically less than about 22. The syntax score measures the complexity of coronary artery disease. Lower score indicates simpler coronary anatomy, making PCI highly effective. PCI may also be preferred in patients with prior chest radiations, severe chest wall deformity, porcelain aorta, and these conditions increase surgical difficulty and operative risk. Clinical factors favoring CABG. Several clinical situations clearly favor surgery. The first is diabetes mellitus. Multiple large clinical trials have consistently shown that diabetic patients with multivessel coronary disease have better long-term survival after CABG than after PCI. Another important indication is left ventricular dysfunction, particularly when ejection fraction is below approximately 35%. CABG may improve myocardial perfusion sufficiently to allow recovery of hibernating myocardium and improve ventricular function. CABG is also preferred for recurrent in-stent restenosis after PCI. Anatomical factors favoring CABG. Anatomy plays an even larger role. CABG is preferred in patients with high syntax scores, diffuse multivessel disease, left main coronary artery disease, extensive coronary calcification, and complex bifurcation lesions. These lesions are difficult to completely treat with PCI. CABG is also favored when patients require another cardiac operation at the same time, such as aortic valve replacement, mitral valve surgery, ascending aorta surgery. In these cases, surgeons can perform bypass grafting during the same operation. Evidence comparing PCI and CABG. The article summarized on the right side reviews long-term outcomes. Patients with three-vessel disease or left main coronary artery disease generally demonstrate better long-term survival with CABG. Although PCI offers quicker recovery, CABG significantly reduces repeat procedures and improves long-term outcomes in appropriately selected patients. Therefore, the choice should always be individualized after discussion by the multidisciplinary heart team. Table 13. Conduit for CABG. The long-term success of CABG depends greatly on graft selection. Saphenous vein graft, or SVG, the most commonly harvested venous graft, is the great saphenous vein. Historically, this was the standard graft. However, its long-term durability is relatively poor. At 10 years, around half of the vein graft becomes completely occluded, and many develops significant atherosclerosis. Despite this, SVGs remain widely used because they are easy to harvest and provide adequate conduit length. Left internal mammary artery, or LIMA. The left internal mammary artery, also called the left internal thoracic artery, is considered the gold standard graft. Its long-term patency is excellent, reaching approximately 90 to 95% even after 15 years. Almost every patient undergoing CABG receives a LIMA graft to the left anterior descending artery, or LAD. This is because the LAD supplies a large portion of the left ventricle. LIMA to LAD grafting significantly improves survival, freedom from myocardial infarction, long-term symptom control, and no need for repeat intervention. Right internal mammary artery, RIMA. The right internal mammary artery can also be used. When both mammary arteries are used, long-term outcomes may be even better in selected younger patients. However, bilateral mammary artery harvesting slightly increases the risk of external wound infection, particularly in diabetic or obese patients. Radial artery. The radial artery has become another popular arterial conduit. Its 5 years patency approaches 85 to 95%, making it superior to vein grafting. However, because the radial artery is muscular, it is prone to vasospasm. Therefore, calcium channel blockers or nitrates are often prescribed after surgery to maintain graft patency. Right gastroepiploic artery. The right gastroepiploic artery is less commonly used. It is usually bypass the right coronary artery. Because harvesting this artery requires opening the abdomen and is technically more demanding. It is reserved for selected patients. Complete arterial revascularization. The table also introduces the concept of complete arterial revascularization. This involves using multiple arterial grafts instead of vein grafts. Arterial grafts remain open much longer, making this strategy especially beneficial in younger patients who have many years of expected survival. Redo CABG. Redo bypass surgery deserves special attention. Repeat CABG carries significantly higher operative risk than the initial surgery. Reasons include dense scar tissue, difficult surgical dissection, previous graft injury, and increased bleeding risk. Therefore, redo surgery is usually reserved for symptomatic patients whose previous grafts have failed and who are not suitable candidates for PCI. Operative issues. The final section highlights important operative considerations. One of the strongest predictors of outcome is left ventricular function. Patients with severe left ventricular dysfunction generally have poorer prognosis. However, carefully selected patients may actually experience dramatic improvement after CABG is viable, myocardium remains. Before surgery, physicians therefore assess myocardial viability. Several imaging modalities are available. Dobutamine stress echocardiography, thallium viability scan, PET scanning, cardiac MRI. If these tests demonstrate viable but hibernating myocardium, surgical revascularization may restore blood flow and significantly improve ventricular function. Dual antiplatelet therapy after PCI. The final evidence summary discusses dual antiplatelet therapy or DAPT. After drug-eluting stent implantation, aspirin is combined with P2Y12 inhibitors. Historically, DAPT was continued for 12 months. However, newer studies suggest that selected low-risk patients may safely receive shorter treatment durations, reducing bleeding complications without significantly increasing ischemic events. Therefore, DAPT duration should always be individualized according to each patient's balance between bleeding risk and ischemic risk. Let's begin with antiplatelet therapy after CABG. One of the major causes of graft failure is platelet activation and thrombose formation. Therefore, antiplatelet medications are crucial to maintain graft patency. Before surgery, certain antiplatelet agents be discontinued to minimize bleeding risk. Clopidogrel and ticagrelor should generally be stopped 5 days before surgery, while prasugrel should be discontinued 7 days before surgery because it produces a stronger and more prolonged platelet inhibition. This timing allows recovery of platelet function and significantly reduces intraoperative bleeding. Dual antiplatelet therapy after CABG. Patients who undergo CABG because of an acute coronary syndrome require continued protection against future thrombotic events. Therefore, dual antiplatelet therapy or DAPT is recommended for approximately 12 months after CABG, especially if surgery is performed within 48 to 72 hours after an acute coronary syndrome. Dual therapy usually consists of aspirin plus a P2Y12 inhibitor such as clopidogrel or ticagrelor. Role of aspirin. Aspirin is the cornerstone of postoperative management. Low-dose aspirin, usually 81 mg daily, should be started approximately 6 hours after surgery, provided there is adequate surgical hemostasis. Unlike dual therapy, aspirin is continued indefinitely because it significantly reduces graft thrombosis and recurrent cardiovascular events. Patients undergoing CABG after PCI. Sometimes patients undergo PCI first but later require CABG. In these situations, the recommended duration of dual antiplatelet therapy after PCI should usually be completed even after bypass surgery. The goal is to protect both coronary stents and the newly implanted bypass grafts. Risk factors for CABG mortality and morbidity. Let's discuss which patients are at high risk for poor surgical outcomes. Risk factors for mortality. The strongest predictors of death after CABG include urgent or emergency surgery. Patients undergoing emergency operations often have an ongoing myocardial infarction, cardiogenic shock, or hemodynamic instability. They naturally have higher operative mortality. Reoperation. Repeat CABG is technically more difficult because of scar tissue and previous grafts. This increases operative complexity and mortality. Advanced age. Older patients generally have more comorbidities, frailty, and reduced physiologic reserve. Age remains an important independent predictor of mortality. Poor left ventricular function. Patients with severe left ventricular dysfunction have weakened myocardial contractility. During surgery, they tolerate ischemia less well and are more prone to postoperative heart failure. Female sex. Historically, women have shown slightly higher operative risks because of smaller coronary arteries, older age of presentation, and more accompanying illnesses. Left main coronary disease. Critical stenosis of the left main artery threatens blood supply to nearly the entire left ventricle. Any interruptions during surgery carry substantial risk. Other high-risk conditions. Additional predictors include cardiogenic shock, ventricular septal rupture, ongoing CPR, dialysis-dependent renal failure, severe COPD, diabetes mellitus, cerebrovascular disease, and peripheral vascular disease. These conditions increase both operative mortality and postoperative complications. Risk factors for postoperative morbidity. Now let's discuss factors associated with prolonged hospitalization and postoperative complications. These include reoperation, emergency surgery, requirement for an intra-aortic balloon pump before surgery, congestive heart failure, combined CABG plus valve surgery, advanced age, chronic kidney disease, COPD, diabetes mellitus, cerebrovascular disease. These patients require closer post-operative monitoring and multidisciplinary management. Procedural complications of CABG. No matter cardiac operation is completely free of complications, let's review the most important ones. Stroke. Stroke remains one of the most feared complications. It usually results from embolization of atherosclerotic plaque, air bubbles, or particulate debris. During manipulation of the ascending aorta and cardiopulmonary bypass. Patients may also develop postoperative cognitive dysfunction, sometimes called pump head, although this is usually temporary. Immunosuppression. Cardiopulmonary bypass activates inflammatory pathways, but paradoxically may also produce temporary immune dysfunction. As a result, patients become more susceptible to postoperative infections. Deep external wound infection. This is a serious complication that may progress to mediastinitis. Risk factors include diabetes, obesity, prolonged surgery, and bilateral internal mammary artery harvesting. Temporary treatment often requires prolonged antibiotics and surgical debridement. Bleeding. Bleeding may result from anticoagulation, platelet dysfunction, or incomplete surgical hemostasis. Some patients require blood transfusion or even return to the operating room. Systemic inflammatory response syndrome. Exposure of blood to the artificial surfaces of the cardiopulmonary bypass circuit activates inflammatory mediators. This systemic inflammatory response can lead to dysfunction of multiple organs. Possible manifestations include myocardial dysfunction, acute kidney injury, neurological injury, respiratory failure, and coagulation abnormalities. Off-pump coronary artery bypass surgery, or OPCAB. Now let's discuss an alternative surgical technique called off-pump coronary artery bypass surgery, or OPCAB. Unlike conventional CABG, OPCAB is performed without using the heart-lung machine. Instead, surgeons operate while the heart continues beating. How is this performed? Special stabilization device immobilize only the small portion of the beating heart where the graft is being attached. Positioning devices gently rotate or elevate the heart, allowing surgeons to access the anterior, lateral, and posterior coronary arteries while maintaining systemic circulation. Advantages. By avoiding cardiopulmonary bypass, OPCAB may reduce systemic inflammatory response, post-operative bleeding, blood transfusion requirements, atrial fibrillation, respiratory complications, renal dysfunctions, intensive care unit, and overall hospitalization. Many patients recover more quickly. Indications. OPCAB is particularly useful in patients at high risk for complications from cardiopulmonary bypass. Examples include patients with heavily calcified ascending aorta, poor left ventricular function, severe peripheral vascular disease, severe COPD, chronic kidney disease, coagulopathy, refusal of blood transfusions such as Jehovah's Witnesses, and elderly high-risk patients. Contraindications. However, OPCAB is not suitable for every patient. Absolute contraindications include severe hemodynamic instability, poor target coronary vessels, diffuse coronary disease, and severely calcified coronary arteries. Relative contraindications include cardiomegaly, critical left main disease, small distal coronary targets, recent myocardial infarction, cardiogenic shock, and an ejection fraction below approximately 35%. Clinical outcomes. Studies have shown that OPCAB can reduce several early postoperative complications. These include lower rates of chest infections, inotropic drug requirement, supraventricular arrhythmias, blood transfusions, ICU stay, overall hospital stay, and postoperative CKMB and troponin release. However, one important limitation is that some studies have demonstrated lower long-term graft patency compared with conventional on-pump CABG. In other words, although patients may recover faster initially, some grafts may not remain open as long over the long term. Clinical trials comparing PCI, CABG, and medical therapy. The figure at the bottom summarizes several landmark trials comparing optimal medical therapy, PCI and CABG, in patients with a stable ischemic heart disease. These studies collectively demonstrate that optimal medical therapy remains the foundation of treatment for stable coronary artery disease. PCI is highly effective for relieving angina and improving symptoms. CABG provides the greatest survival benefits in selected high-risk patients, particularly those with left main disease, multivessel coronary artery disease, diabetes, or impaired left ventricular function. Therefore, treatment decisions should always be individualized by multidisciplinary heart team after considering coronary anatomy, patients' comorbidities, surgical risk, and patients' preferences. Figure 42, congestive heart failure. Let's begin with the figure 42 shown in the middle of the page. This is an excellent overview because it links the underlying disease process with the body's compensatory mechanisms and the clinical manifestations that we see at the bedside. Low output heart failure. Starting on the upper left side of figure 42, notice the heading low output heart failure. This is by far the most common type of heart failure encountered in clinical practice. Low output heart failure simply means that the heart is unable to generate sufficient cardiac output to meet the body's demands. Remember, the equation cardiac output equals heart rate multiplied by stroke volume. If a stroke volume falls because the ventricle cannot contract properly or cannot fill adequately, cardiac output decreases. Reduced cardiac output leads to decreased tissue perfusion, explaining why patients complain of fatigue, weakness, dizziness, and exercise intolerance. Systolic dysfunction. Now look at the first heart illustration on the left of figure 42 labeled systolic dysfunction. The figure shows a sequence of events beginning with injury and ischemia of the myocardium. Common causes include coronary artery disease, myocardial infarction, viral myocarditis, or dilated cardiomyopathy. As myocardial cells die, they are replaced by scar tissue. Unlike normal myocardium, scar tissue cannot contract. The ventricle therefore becomes thin, weakened, and dilated as illustrated in the figure. Because the ventricular muscle contracts poorly, less blood is ejected during systole. Consequently, the ejection fraction decreases, typically to less than 40%. This condition is referred to as a heart failure with reduced ejection fraction, or HFrEF. Clinically, patients may present with progressive shortness of breath, fatigue, reduced exercise tolerance, pulmonary edema, and eventually signs of poor organ perfusion. An important point to remember is that as blood remains in the ventricle after each contraction, the ventricle gradually enlarges. This ventricular remodeling further worsens cardiac function, creating a vicious cycle. Diastolic dysfunction. Now shift your attention to the second heart illustration in figure 42 labeled diastolic dysfunction. Unlike systolic dysfunction, the ventricle contracts relatively normally. The problem lies in relaxation. Notice how the figure describes infiltration and fibrosis, resulting in a thick, stiff myocardium. Because the ventricular wall has lost its compliance, it cannot relax adequately during diastole. As a result, ventricular filling becomes impaired, although the ventricle ejection is normal. It ejects normal percentage of the blood it receives. The total amount of blood entering the ventricular is reduced. Therefore, stroke volume and cardiac output is still decline. This condition is called heart failure with preserved ejection fraction, or HFpEF. Patients often have a normal ejection fraction, usually greater than 50%, yet they experience symptoms identical to systolic heart failure because elevated filling pressures are transmitted backward into the pulmonary circulation. The most common causes include chronic hypertension leading to left ventricular hypertrophy, aging, diabetes mellitus, obesity, hypertrophic cardiomyopathy, and restrictive cardiomyopathies. High output heart failure. Now move your eyes to the upper right corner of figure 42 where you'll find high output heart failure. This is much less common, but it is an important concept. In high output heart failure, the heart itself mainly initially be structurally normal. However, the body's metabolic demands become so great that even an increased cardiac output cannot meet tissue's requirements. Examples include severe anemia, where the reduced oxygen carrying capacity requires increased blood flow. Hyperthyroidism, where metabolism is markedly accelerated. Pregnancy, arteriovenous fistulas, beriberi, caused by the thiamine deficiency, and sepsis. Eventually, the persistent increase in cardiac workload causes ventricular dilation and heart failure. Increased cardiac workload. Now return to the center of figure 42. Notice that all three pathways, systolic dysfunction, diastolic dysfunction, and high output heart failure converge toward increased cardiac workload. The figure highlights three major contributors: myocardial stress, volume overload, pressure overload. Pressure overload occurs in conditions such as hypertension and aortic stenosis, forcing the ventricle to generate higher pressures. Volume overload occurs in conditions such as mitral regurgitation and aortic regurgitation, where excessive blood volume stretches the ventricle. Initially, these adaptations maintain cardiac output, but chronic overload eventually leads to ventricular remodeling and worsening heart failure. Figure 43, jugular venous pulse, JVP waveform. Now that we have discussed the pathophysiology of heart failure in figure 42, let's move to figure 43, located at the bottom of this page. This figure is extremely important because it teaches us how to interpret the jugular venous pulse, or JVP, one of the most valuable bedside tools for assessing a patient's right-sided heart function and volume status. Before discussing each waveform, remember that the jugular venous pulse reflects pressure changes in the right atrium throughout the cardiac cycle. Unlike the carotid pulse, the JVP is not palpable. It has multiple waveforms. It changes with respiration and it can be reduced by gentle pressure at the base of the neck. A careful examination of the JVP can provide valuable information about the right atrial pressure, right ventricular function, tricuspid valve disease, precordial disease, and overall fluid status. Carotid pulse. Let's first look at the top of the tracing in figure 43, which represents the carotid pulse. The carotid pulse is produced by left ventricular systolic ejection into the aorta. Unlike the jugular venous pulse, it has a single brisk upstroke. It easily is palpable and is not affected by changes in the respiration or body position. We include carotid pulse here because it helps us correlate arterial pulsations with the venous pulse during the cardiac cycle. Jugular venous pulse waveform. Now move your attention to the second tracing labeled JVP waveform. Notice that the waveform consists of three positive waves, the A, C, and V waves, and two downward descendants, the X and Y descendants. Each component corresponds to the specific mechanical event occurring in the right atrium of right ventricle. The A wave. Let's begin with the A wave, which is the first positive deflection. The A wave represents right atrial contraction. It occurs at the end of diastole just before the tricuspid valve closes and immediately after P wave on the ECG. Under normal circumstances, the atrium contracts and pushes blood into the right ventricle, producing a modest rise in the right atrial pressure. The size of the A wave increases whenever the atrium has to contract against increased resistance. Examples include pulmonary hypertension, tricuspid stenosis, right ventricular hypertrophy. One classic abnormality is the Canon A wave, which occurs in complete or third-degree atrioventricular block. Here, the atria and ventricles contract independently, so occasionally the atrium contracts against a closed tricuspid valve, producing a very large A wave. Conversely, in atrial fibrillation, there is no organized atrial contraction, so the A wave disappears completely. This is one of the hallmark findings in patients with atrial fibrillation. The C wave. This small positive wave occurs during the early phase of ventricular systole. It is produced by the bulging of the closed tricuspid valve back into the right atrium as the right ventricle begins to contract. In normal individuals, the C wave is usually small and may not always be visible clinically. The X descendant. Following the C wave, notice the X descendant, which is a downward movement in the waveform. The X descendant represents atrial relaxations and the downward displacement of the tricuspid valve during ventricular systole. As the ventricle contracts and pulls the tricuspid valve downward, right atrial pressure falls, producing this descent. A prominent X descent is classically seen in cardiac tamponade because ventricular contraction continues while ventricular filling is severely restricted by the precordial fluid. Therefore, When evaluating a patient with suspected tamponade, observing a preserved or exaggerated X descent is an important bedside clue. The V wave. The V waves represents passive filling of the right atrium while the tricuspid valve remains closed during ventricular systole. As venous blood continues returning to the heart, right atrial pressure gradually rises until the tricuspid valve opens. A very large V wave strongly suggests tricuspid regurgitation because the incompetent tricuspid valve allows blood to flow backward from the right ventricle into the right atrium during systole. Right atrial pressure rises dramatically, producing giant V waves. The Y descendant. Finally, we come to the Y descendant. This represents rapid emptying of the right atrium into the right ventricle immediately after the tricuspid valve opens at the beginning of diastole. Normally, blood flows quickly into the ventricle, causing atrial pressure to fall. A prominent Y descent is characteristic of constrictive pericarditis, where ventricular filling occurs rapidly in early diastole but is abruptly halted by the rigid pericardium. In contrast, in cardiac tamponade, ventricular filling remains restricted throughout diastole, so the Y descendant becomes absent or markedly blunted. This difference helps distinguish constrictive pericarditis from cardiac tamponade. Correlations with heart sounds and ECG. Now, notice the lower portion of figure 43 where the JVP waveform is aligned with the heart sound and the ECG. This correlation helps us understand the timing of each event. The A wave occurs shortly after the P wave because the atrial depolarization triggers atrial contraction. The QRS complex initiates ventricular systole, during which the C wave appears at the first heart sound is 1, is heard as mitral and tricuspid valve closes. During ventricular systole, the X descent follows as the atrium relaxes. Near the end of systole, the V wave develops while the atrium fills. Finally, after the second heart sound, or S2, the tricuspid valve opens, allowing rapid ventricular filling and producing the Y descendant. Understanding these relationships allows clinicians to connect electrical activity, valve movement, heart sounds, and venous pressure changes during each phase of the cardiac cycle. To summarize, PCI is less invasive, provides rapid reperfusion, and is the preferred treatment for STEMI, many acute coronary syndromes, and patients with less complex coronary artery disease. CABG provides more complete and durable revascularization and is preferred for the left main disease, complex multivessel disease, diabetes, and multivessel involvement, high syntax score, and selected patients with reduced left ventricular function. The LIMA to LAD graft is the gold standard because of its excellent long-term patency, and arterial grafts generally have better long-term durability than vein grafts. Appropriate antiplatelet management is essential. Discontinue clopidogrel and ticagrelor 5 days before CABG, prasugrel 7 days before surgery. Continue lifelong aspirin. And prescribe 12 months of dual antiplatelet therapy after CABG in patients with acute coronary syndrome. Heart failure is a clinical syndrome caused by impaired ventricular pumping or filling, resulting in inadequate cardiac output and congestion. Understanding its classification, compensatory mechanism, and difference between left and right-sided heart failure is fundamental for diagnosis and management. Jugular venous pulse (JVP) examination remains an essential bedside skill, providing important clues to the right heart function and conditions such as tricuspid regurgitation, cardiac tamponade, constrictive pericarditis, atrial fibrillation, and complete heart block. The most important principle: always individualize patient management by integrating the clinical presentation, coronary anatomy, cardiac function, physical examination, imaging findings, and multidisciplinary heart team discussion to achieve the best long-term cardiovascular outcomes. Thanks for attending the lecture. So if you're new to the channel, don't forget to like and subscribe and press the bell icon. See you in the next lecture videos.